and welcome to the Support Hospital Opioid Use Disorder Treatment Shout Texas ECHO. Please note that we are recording these sessions for later distribution. Please note that anything listed in the chat will not appear in the recording. My name is Shreya Prasanna and I will be facilitating today's session. A few quick announcements before we begin. To help us with attendance, please enter your name, affiliation, and email into the chat function. To access the chat feature, please click on the speech bubble icon at the navigation bar at the bottom of your window. To all the BeWell Texas providers, please make sure that you identify yourselves during the session, or if you're joining via phone, please email your name and phone number to bewelltx@utisca.edu. Some housekeeping, please stay muted unless you're speaking, and we do encourage you to speak. If you've joined by computer, your mute button is on the bottom left of your Zoom controls. If you joined by phone, please press *6. We also encourage you to unmute and speak, especially during the discussion portion of our session. We do request you to keep your comments brief so that we can hear from as many of you as possible. You can also use the chat feature to share comments and questions. Please note that no protected health information is allowed in either the chat or the discussion, and that includes names, emails, addresses, or anything that can easily identify an individual. If you would like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. Towards the end of the session, the Shout Texas team will send out a link to an evaluation survey. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Our didactic today is on facilitators and barriers to implementing hospital-based addiction treatment services and will be presented by Alanna Boulton. Following that, we will discuss a case presented by Dr. Dan Handayan. We will start with some introductions, followed by didactics, BeWell program announcements, case presentation, and open discussion. Thank you all again for joining today's ECHO. In the spirit of all teach, all learn, we encourage you all to share your questions, experiences, and insights in today's conversation. And with that, we will go ahead and do some introductions. Alanna.
Hi there. Good afternoon, everyone. My name is Alanna Boulton. I am part of the Shout Texas hub team at Dell Medical School at the University of Texas at Austin.
Thank you so much for joining us. Dr. Ramesh.
Hey, everyone. I'm Jan Ramesh. I'm one of the hospitalists at Dell Seton and a hub team member for Shout. Excited to be here today.
Thank you so much for joining us. Dr. Weems.
Hey, I'm John Weems, an addiction doc and internal medicine physician at Community Care in Austin and a member of the hub team. Welcome, everybody.
Thank you so much. Dr. Lindsay.
Hi, everyone. Adrienne Lindsay, Director of the Center for Substance Use Training and Telementoring at Health. Thanks for being here.
Thank you so much. Dr. Handayan.
My name is Dr. Daniel Handayan. I'm a family medicine attending over here at DTAR Family Medicine Residency Program in Victoria, Texas, and we are a new satellite member of the Shout program.
Thank you so much for joining us. Jasmine Vidal.
Hello, everyone. My name is Jasmine Vidal, and I'm the CSTAT coordinator. Thank you for joining us today.
Thank you. And with that, we will get started with our didactic. Alanna, you can take it away when you're ready.
All right, let me share my screen. Someone give me a nod that it's working perfect. All right, and then let me just get my presenter view. Sorry, everyone. All right, so thanks everyone so much for joining us this afternoon. As I mentioned before, my name is Alanna Boulton, and I am the Program Administrator of Addiction Care Ecosystems at Dell Medical School at the University of Texas at Austin. And in that role, I have the privilege of helping to lead a team called Shout Texas, which is what we're doing today. And Shout is Support Hospital Opioid Use Disorder Treatment in Texas, and we are dedicated to expanding access to evidence-based best practice care for patients with opioid use disorder and other use disorders in acute care hospital settings. And today I'm going to share with you some of the pearls of wisdom that we've learned over the last 4.5, almost 5 years of doing this work at our hospital and other hospitals across the state of Texas, and hopefully share some of that with you so that you can take that back to your individual practice settings. First of all, disclosures. I don't have any relevant financial relationships to disclose in relation to the content of this talk today. And everything that I am going to share, that my views and opinions are my own. They don't necessarily reflect the views of UT Health San Antonio, UT Health Austin, Dell Medical School, UT Austin, or Texas Health and Human Services. I'm speaking essentially as a private citizen today, so I'm excited to share what I have, what we've learned. One final disclosure is that I do not have any personal lived experience with addiction or substance use disorders. I have dedicated my career to doing this work and to expanding access to compassionate care for people who do have addiction and substance use disorders. But it is important, it's what we talk about often, the importance of centering the voices of people with lived experience. So in all transparency, I personally do not have that lived experience, but I am excited to share what I have learned in my professional experience with you today. With that being said, what we're going to spend probably a little bit more than half of our time with today is describing the work that we did at our hospital setting and the way that we expanded that treatment model to other hospitals across the state of Texas, and the impact that we've made in hospitals for patients being seen by hospitalists in the hospital. Then we'll talk about some of what we've learned, identifying those facilitators, barriers, strengths, weaknesses of doing this work, again, in our hospital and hospitals across the state. And then hopefully being able to share that with you to take that back into your individual practice settings and have some conversations around how to address specific struggles or pain points in your areas, or to leverage those facilitators or those strengths that you do have. So the too long didn't read is that we started a volunteer interdisciplinary team at our hospital in Austin, Dell Medical Center, that was dedicated to hardwiring the screening and treatment of patients with opioid use disorder in standard of practice care within our hospital walls. So none of these people had specific training in addiction medicine. None of them had specific time carved out of their FTE to do this work. This was just volunteers that wanted to make a difference. And then we were successful in doing that in our hospital setting. So we expanded it to other hospitals across the state and have been able to see a pretty big impact in the state of Texas. And we did that in sort of two phases. So again, we originally created this HBOT team. So HBOT is hospital-based opioid treatment. And our team was called the B team for buprenorphine. And again, it was a team of volunteers. So none of these people were hired specifically to do this work. None of these people had any specific training in addiction medicine or addiction psychiatry or addiction care. And it was truly an interprofessional team. We had hospitalists, psychiatrists, PAs, NPs, social workers, pharmacists, residents, med students. We even had a chaplain on the team. We had a floor nurse on the team. And these are all just people who, for one reason or another, were interested in trying to provide this care to patients in our hospital setting that they weren't receiving it already. And we were pretty successful in doing that. Over the first 2 years of the program, we saw some pretty significant success, which I'll share shortly. And because of those successes, we received some funding from the state of Texas to develop this program called Shout Texas, which is essentially the vehicle that we use to disseminate the B team model or the B team ethos to other hospitals across the state of Texas. So the team doing the work is the B team, if you will, and then the team doing the dissemination is Shout Texas. And again, so our B team was very successful. I mentioned this before. So we started a process for screening patients, starting patients on treatment for opioid use disorder in the hospital setting, and discharging them with coordinated outpatient care before they left the hospital. And you can see that over the course of time, not only did our screening rates go up, so just the whole numbers of patients that we were seeing, we got really good at minimizing the deltas between these stages in the cascade of care, right? So the difference between the number of patients screened and the number of patients started on medications and the number of patients discharged with coordinated care gets smaller and smaller as time goes on, even while those volumes are increasing. And we were so successful in doing this that we were actually recognized by the Society of Hospital Medicine, and they awarded us one of their national awards for excellence in teamwork in 2021, I think. And we got a little bit better at taking pictures as well. So we're learning a lot as we're going. And so then we decided that we wanted to take this show on the road, if you will. So we received funding again from the state of Texas to share what we had learned and to support other hospitals across the state in doing this work as well. So over the next 3 years, we're in our 4th year now, we expanded to helping teams do similar work in Fort Worth, in Dallas, in Temple, another hospital here in Austin, and in Victoria, Texas. We just recently onboarded a new hospital in Victoria, Texas, and we are really hoping to onboard a hospital in Houston. I put it on here today as a practice of manifestation. If I just say it out loud enough times, eventually it will happen, but we're hoping to bring them on board before the end of this fiscal year. And this work was really successful as well. So we were once again successful in supporting other geographically dispersed teams to stand up programs similar to ours, not exactly the same, but similar to ours, with the same goal of treating patients with opioid use disorder in the hospital setting, just as a standard of care best practice. So you can see this in 2020, nothing was happening, or at least nothing was happening as part of the Shout Texas coordinated informal approach. And then over time, not only do the number of patients seen increase, the delta between those cascades of care are decreasing, and then the number of hospitals that we have on board are also increasing as well. And then again, it's really important, I think this is an important takeaway. So this is our Shout Texas team, and we have gotten really good at disseminating knowledge. One thing that we didn't want to do was establish ourselves as the experts in doing this and essentially hoard that knowledge. We don't go in as on the ground consultants who stand up a program, turn it on and hand over the keys and walk out the door. We approach this as an actual knowledge dissemination approach. So we teach and mentor and guide and help other folks in other hospitals across the state to do this work. It doesn't actually serve the people of the state of Texas and all of the people who need help for us to hoard this knowledge internally. It's the ethos, the cornerstone of the Shout Texas program, or the Shout Texas model, is disseminating knowledge as far as we can get it. And then one quick aside, everything that I've said so far today has been specific to hospitals and specific to opioid use disorder, just because of the, the focus of the work that we're doing and the focus of this echo today. But I do think it's important to say out loud and point out that I do think that this model, or this approach, is transferable and is applicable to other use disorders, and I think other practice settings. You can see in this graph in fiscal year 23, we also started treating alcohol use disorder with a similar model to our B team model, with similar success as well, right? So we're going to continue monitoring that and evolving that within our walls before we start expanding that externally to other hospitals as well. But I think that's a good takeaway from this conversation, that a lot of what we're going to talk about next, as far as what works and what doesn't work, is applicable to other use disorders, other practice settings, and patients in different stages of change and contemplation, or with different self-defined recovery goals. And then this is the main takeaway, right, of the Shout Texas program. So this is all of our partner hospitals. This doesn't include our hospital at Dell Seton. These are our partner hospitals, our spoke sites across the state. They've been able to screen in the 3 years that we were doing this work, and again, we're in our 4th year of doing it now, screen over 7,000 patients for opioid use disorder and start over 3,000 of those patients on medications for opioid use disorder. And this is just work that wasn't happening before, right? It might have been happening to some extent, but not in a concerted way, not in a formalized way, and the measurement certainly wasn't happening. One additional quick aside before we move into kind of the nitty-gritty and what we learned is everything that I've shared so far, presented these charts and these numbers and these graphs, and we talk about things in kind of these grandiose terms of impact and things that we're doing and dollars and cents. But I do want to take a pause and say out loud that it is important to think about impact on an individual level as well. Of course, I love being able to share that we've screened over 7,000 patients, but even if those numbers were in single digits or in the teens, that would still be an impact, right? That's still individual lives that are receiving care that they wouldn't have normally received. So this is a quote or feedback that we actually got, excuse me, from the clinical supervisor at the outpatient clinic that we work very closely with after we treated and discharged a patient in our hospital to ongoing outpatient care at their clinic setting. And this was feedback that we got from that clinic supervisor after they met with the patient. And I'm not going to read all of it to you, but the bolded part was that the patient shared, their perception or their reaction to their hospital course was surprising, right? It seemed that they really, that it was about his feelings and almost disbelief that the team in the hospital actually really cared about him. And then she shared that it was sort of heartbreaking, but really awesome to really know about the impact that we have. So impact can be just on an individual patient level. So I think one of the kind of mottos of the B team is not to let perfect be the enemy of good. If you are interested in doing this work in your practice setting, you don't need to come out of the gate swinging and treating hundreds and hundreds of patients. Even one patient at a time is one more patient than was receiving services before. So just to put that kind of in context, or to give a kind of a relative feel for it. Okay, so I talked about what we did, and I'm going to talk not so much about how we did it, but what we learned as we did it. And I don't have enough time today to share the magic that is the REP implementation science framework with you. But these slides will go out later. You're more than welcome to look at them. And if you're interested, please reach out to me. I would love to share with you. But before we could decide to disseminate this work out to other hospitals where we could help other folks do this work, we had to figure out why we were successful in doing what we did. And that is what the preconditions steps of the REP framework are, which is to evaluate what the successful thing, the effective program is, evaluate that, figure out the core elements that support that project's success, and leverage those moving forward. So we did exactly that. We look back retroactively at meeting minutes, emails, project charters, agendas, any sort of documentation that we had around the idea of standing up, creating, planning, implementing, changing the B team work that we did at our hospital. And we went through all of that documentation and we pulled out core program elements. And for the purposes of this slide, these are the facilitator program elements. These are things that addressed or eliminated barriers to success. So these are essentially the pieces that were helping us be successful in our work. And those were not in order of importance. Having a local dedicated clinical champion. And I say dedicated in the personal sense, not the employment sense. So not someone who was hired specifically for this work, but someone who was personally dedicated to the mission, if you will. Having executive or leadership level support for the work, or at least blessing. We can go I can delve deeper into my personal feelings on this, but it is important. No program is going to be successful in a hospital setting or any clinic setting if there's not upward support for it. Having a true interprofessional and multidisciplinary team, again, especially in a hospital setting, it's very team-based. You can't just have a group of 1 or 2 physicians trying to lead change in a hospital without having other members of the care team on board and other disciplines involved. Collaboration to ensure care coordination. So this is collaboration within the hospital, within the different teams and units, but this is also collaboration with partners external to the hospital. Sometimes hospitals have their own affiliated outpatient clinics. We do not. So we were successful in building relationships and collaborating with our outpatient partners to help our shared patients. A sense of volunteerism and team building, or kind of that coalition or co-conspirator feel that this is people who really want to do this work, who are helping each other to do something really exciting and really cool for their patients. A consultative service model that also involves coaching and development. So we wanted to move away from this concept of like, you just consult the B team. The idea of the B team was teaching and guiding and just-in-time training and actual development of skill throughout the hospital, throughout the teams, not just on our team. Obviously, financial sustainability, that's not important, or that's not surprising, excuse me, while it didn't cost us any money to stand up the team that we had at Dell Seton, to stand up the B team. That is, of course, something that leaders and executives are interested in all the time, is what is the financial sustainability model for this? What is this going to cost us in the long term? Is this going to create a revenue in the long term, or will this reduce utilization or something along those lines? And then, of course, ongoing education and stigma reduction efforts. So all of these things were facilitators or supportive elements of the B team model in the hospital setting. So we kept all of these elements in the forefront of the expansion efforts that we had, right? So we built this package, we packaged this intervention, and we reached out and shopped it around to other hospitals and reached out and helped their teams to implement those that program always with these core program elements, these facilitators in mind. And then we asked them about it later. So once all of these hospitals that we work with, once they got through their implementation, pretty stable, kind of in just the monitoring and evolution phases, we met with them and we asked them, what was your experience like? What worked well about the Shout Texas expansion model? What didn't work so great? Can this work in other hospitals? Did it work in your hospital? And what are other key learnings that you have or that we can glean from your experience to further evolve this dissemination method or this expansion effort to make it even more successful and easier for the next generation of hospitals doing this work? And this is what we learned. So this list is much longer, but these are kind of the main ones that I put on here. But all of our partner hospitals, when we interviewed them, they shared that having pre-packaged resources and educational materials was very important. Again, it saves on time. We Shout Texas created a resource library that lives free and freely available on our website, which maybe someone from Echo IT could throw in the chat for me. Everything is there. Anyone is welcome to use and download any of that however they see fit. And that really saved our expansion sites time. They didn't have to develop these materials or these processes for themselves. It was already prepackaged, ready to go. We also provided logistic support and implementation plan guidance. And this one is very near and dear to my heart because this speaks to that project management or that change management piece, right? So we provided the support for how do you project plan? How do you build an implementation plan? How do you advocate upwards to leadership? How do you build a business case? How do you do those more project management, less clinical service pieces that care teams aren't always familiar with, especially if they have been so focused on just delivering care to patients. They're not always knowledgeable of those project management or those logistical elements and that support that we provide. And then, of course, seed funding, everyone found that very, very helpful. Shout Texas does provide our partner hospital sites with modest annual funding to support their project work. Oftentimes, this is used to offset FTE for the clinical champion or other project team members to do education, to do trainings and things like that, or it can be used for other things as well. But that funding has been found useful. And then lastly, the Shout Texas Network and Community of Learning or Community of Practice, which is not just all of our partner hospitals across the state, but it's actually all of you on the call today. So the Shout Texas Echo Series is part of our coordinated effort to develop a network and a community of learning that's statewide. So all of the conversations we have on these sessions every month, all of the didactics, all of the case presentations, actually go into contributing to the collective learning of the Shout Texas network of all of our hub team members, all of our partner hospitals and prospective hospitals or other folks, individual clinicians, individual contributors who are trying to stand up this work in their practice settings as well. And then barriers that were identified as things that made it harder to do this work or things that we can focus on changing moving forward is outpatient to follow-up care. So access in the outpatient setting is something that we definitely have an eye on. I know a lot of work is happening in this space throughout the state. There's opioid litigation funds coming down. I know BeWell is doing a lot of work here, but it is a pain point that gets brought up pretty regularly, especially in consideration of our more rural hospital sites. Lots of struggle with pharmacy, specific hospital pharmacies or hospital pharmacy teams who didn't want to stock various medications for opioid use disorder or who had local policies that really restricted the number of prescribers who could order, administer, and prescribe medications for opioid use disorder above and beyond the national regulations. And then also struggles with outpatient pharmacies doing the same thing, not wanting to stock medications for opioid use disorder or not wanting to serve patients or providing very stigmatizing care. Ongoing struggles there. Nursing education is another piece that often is identified and is something that we need to continue working on. We all know nurses are the cornerstone of care delivery, and they're the ones who see and interact with the patients on a more regular basis than the prescribers do. So having pre-packaged educational materials for them so that they feel informed, so that they feel like they can advocate for their patients, and so they feel like they can deliver the best possible care for their patients is super important. And it's something that we are focusing on moving forward. And then finally, integration into other hospital units and other disciplines. And this is a struggle that we had that we approached with this idea of planned obsolescence of the B team. We did not want to create a consult service for opioid use disorder or addictions, because we really do believe that's the cornerstone of the B team model, is that everybody in the hospital setting can screen and treat patients for opioid use disorder as a standard of practice, best treatment for standard of care in the hospital setting, unless the patient has a very specific disease course or very complex disease that does require addiction medicine or psychiatric consultation as well. But it's really easy for other units to see these teams, the B team or the teams at these other hospitals, and think, okay, they're going to do that. I don't have to worry about this because there's a team that's doing this work. And while that's better than nothing, that doesn't solve the ongoing problem, right? And that it's not going to meet the needs of the hospital or of the patients, right? The patients showing up to the hospital. So integration of this mindset into other units and other teams is a struggle, and is something that we're also keeping an eye on. And then these are just quotes that we got from those interviews that map back to this facilitators and barriers that we just looked at on that last slide. Again, I'm not going to read these to you. These slides will go out. You can read them after. But again, this is just actual feedback from the folks at the hospital sites that we interviewed about their perceptions of the program. So key lessons or take-home points, mapping back to our learning objectives, right? Treating patients with opioid use disorder or other substance use disorders in the hospital setting is important and is something that can be done, and that's something that can have a really big impact on individual patient lives and the larger population health en masse. And insight from data analysis and stakeholder interviews can inform changes and evolution to programs. So that's what we did, not just with the B team and not just with the Shout Texas model, but what our hospital sites do as well day to day. It's just a listing of the facilitators and the barriers. And then the last take-home point that I want to say, this is like the main take-home point, is yes, a multidisciplinary team or interprofessional team can promote an increase in screening and treatment of substance use, or for the purposes of this conversation, opioid use disorder for hospitalized patients, even in the absence of existing structural support or systemic support. So this can absolutely happen in your practice setting, even if you think it can't. Please reach out to us. We're happy to help you. And then again, bringing it back to the individual patient level, that every patient that's provided with substance use or addiction treatment or recovery support care in the acute setting is a patient who just a couple of years ago was not receiving that care. So every patient matters. Every interaction with every patient matters. It doesn't have to be this huge, big, grandiose, giant program right out of the gate. It can just be individual patients and changing the way that they experience the healthcare system and the way that they think about or self-define their recovery goals. And that is all that I have. Would love to open it up for questions, maybe about our process, but also specific to individual practice settings and struggles or successes that you've had.
Thank you so much, Alanna. This was a wonderful presentation. I am going to open up the floor for any questions or comments.
I just want to say, from the JPS site, Alanna, your team has done more than helped educate us and facilitate the education of our hospital staff. But when it came to barriers, and we can spend another hour and a half on this talk, but when it came to barriers, your team, John, your pharmacy team, really gave us a lot of educational material, evidence-based practices to take to those people in key stakeholder positions, to show them the evidence. And a lot of times that was the relative straw that got us over the camel's hump, if that analogy makes any sense. But anyways, it was, instrumental in getting us to enjoy the success that we've had thus far. So thank you.
Thanks, Dustin. That's so kind for you to say.
Indeed.
I have a question, Alanna, if I may.
Of course.
Since you have implemented this in many settings now, if you have a new setting that wants to start the Shout program, would you do a readiness assessment? And if you would, what would you look for? Like, what would make that site the most compatible for this program?
That's a great question. And the answer is yes, we would do, or the person who's maybe interested in doing this should do some sort of kind of readiness assessment or current state assessment. The biggest things that we look for and the things that are pretty necessary to getting the project off the ground are having that personally dedicated clinical champion, someone who's interested in doing this work, and having a team that's also interested in it, right? So it doesn't have to be a huge team. I know we showed our pictures and like at one point we had like 15 people on our team. It doesn't need to be a team that big. It can be 2 or 3 people, but having kind of that team-based approach, people who are just intrinsically interested in doing this work is super important. And then in addition to that, to support that, there does need to be some sort of structure of support or leadership support, or at the very least leadership apathy. And that's actually one of the things that we talk about we have a manuscript, an article that's going to be coming out in the next couple of months around our implementation science approach. But the idea of trying to chase down leadership approval versus trying to obtain like leadership saying, okay, as long as it doesn't cost us any money and you're not asking for anything from us, go ahead and do this work if you want to, and then you can come back and tell us how it went afterwards. So those are the 2 main things: is a team interested in doing this work, and then some sort of leadership approval or support, and then having the medications on formulary or accessible in the hospital. That's the main thing. From there, and anything else is a bonus, but we can work with anything from there as far as workflows or current perception or education levels. Like that's all things that we can address with the implementation.
Thank you, Alanna. Well, all right. We'll keep the questions coming in the chat, but thank you so much, Alanna, for this wonderful presentation. And it's really nice for us to situate ourselves where we are in the SHOUT program and how this ECHO is also a part of it. And with that, we will now move on to the next part of our session. Karen, if you could please bring up the BVEL program announcements. Thank you so much. To claim the CME credits, you must text by midnight tonight. Please text attend 1009-5784 to 844-502-1338. Next slide, please. I will call on McKenna Garcia to please unmute and tell us a bit more about this project.
Hi, everybody. I'm McKenna. I'm a research assistant here at BeWell. I just wanted to thank you guys for giving me a moment of your time to speak about a new patient study opportunity we have. So it involves a therapeutic app that serves as an add-on to those who have recently begun buprenorphine treatment for opioid use disorder. It could potentially help participants stay engaged in their treatment for longer. It gives them access to 24/7 individualized advice and therapeutic support in between their appointments. So as cravings come up, if they're unable to reach their provider in a time of need. So for 13 weeks, they would have 2 virtual visits with our team, as well as complete some at-home drug screens. They will be compensated for their time and their participation. I am going to send a follow-up email out to everybody just to relist the details of the study, as well as provide a flyer you can give to any interested patients. I can also, if you would like, set up a time to have a short Zoom call with your team to present on this and answer any questions you guys may have. So thank you again for your time. And if anybody has any immediate questions, please just let me know.
Thank you so much, McKenna, for sharing this. Next slide, please. Join CSTAT for our session titled Mitigating Grief and Loss Post-Pandemic. This will be next Tuesday on May 21st, and we will be dropping the link in the chat. Next slide. Join us on Thursday, May 30th for an exciting panel conversation with 3 experts across Texas, leveraging innovative models for the delivery of medications for opioid use disorder in underserved rural areas. To register, please visit texas.org/sessions. Next slide. Our next Shout Echo will be on Thursday, June 20th. Please join us for an interesting session with Dr. Mitch Katona. And with that, we will move on to our case. Karen, if you could please bring up the case form, and Dr. Handayan, you can take it away whenever you're ready.
All right, thank you. So this is a case of a 48-year-old female who was seen at our hospital on our family medicine residency service. Primary reason for admission is hepatic encephalopathy. So this case not only highlights some of the patients we have here in Victoria, Texas, which considered a rural area of South Texas, or kind of over here in between, or basically 2 hours south of Houston, is what I'd say. But we're about 2 hours, a little bit over 2 hours from San Antonio, a little bit over 2 hours from Austin, 2 hours of Houston, and about a little bit over an hour from Corpus Christi. And we're right about 30 miles inland from Port Lavaca. So we service a large area, I would say, in this region. And I am I'm new to this attending role here at DTAR. I did my residency here in family medicine at DTAR Hospital. We're affiliated with Texas A&M University. So I just wanted to bring up this patient case because the history and the timeline and how certain things evolved with this patient case, even from when I was a resident. We had seen her in the residency continuity clinic and managed many of her underlying conditions. So the patient initially presented to the ER for altered mental status. She was mildly hypotensive, appeared to be relatively asymptomatic. Ammonia level was found to be significantly elevated. And she was admitted to the floor. She has a pretty extensive past medical history, as you can tell, including anxiety, bipolar disorder, chronic back pain, hepatitis C, DVT, diabetes, amputations, history of IV drug use, opioid use disorder, stimulant use disorder. Listed here are some of her home medications and some of the hospital medications that we used. Her support systems, she currently lives at home with her son. She's on disability. Transportation is primarily provided by her son and her insurance provider. Psychiatric history of bipolar disorder, anxiety, history of psychosis, related to stimulant use disorder. So a brief hospital course. She was met to the floor for workup, placed on bowel rest. CT scan of the abdomen showed she had colitis. Urine drug screen from the ER was positive for methamphetamine and opioids. She was also positive for C. diff at the time, started on oral vancomycin. Her confusion improved when started on lactulose over 2 to 3 days. And I bring this patient case up is because this was one not too long ago. This was probably when I first came back last year that we had started her on Suboxone in the hospital. Now on formulary in our hospital, we only have the 2 milligram tablets of Suboxone. So we were able to get her up to 8 milligrams. Her reported history is use of heroin. that she uses IV, and she says she doesn't use it as often as she did before in the past, but she still uses it about every few days, he said so. So we had started her on that while she was in the hospital. And urinalysis, she had some leukocytes and bacteria, started Rocephin. So she has a history of hepatitis C as well. Rapid quadrant ultrasound was ordered to evaluate for malignancy. She did have a suspected liver mass on CT scan and ultrasound to be followed up in 6 months. And she was referred to the hematology oncology service as well while in the hospital, and she has follow up with them. So interestingly enough, we had just started addiction medicine clinic. That's kind of a subspecialty clinic with the residency continuity clinic. We meet about every 2 to 3 Fridays out of the month. So we were able to have her establish care in that clinic. I have to actually see her tomorrow. And some other things we had checked on the PDMP, pertinent findings from the past, temazepam, pregabalin, tramadol, and Suboxone. So substance use history, looking back through some of her EDSs, because she's been admitted to the hospital multiple times in the past. She had been positive for cocaine, alcohol. She is a smoker, as well as methamphetamine, and prescription opioids. And after discussion with her in the past, she has had substance use counseling. And at present, I checked off no, because we are working on getting her into our local recovery outreach center for counseling services. She has had inpatient substance use treatment in the past, has been to residential treatment, has been on methadone as well, all of which she did not continue afterwards. And 12-step, she also has been a part of NA in the past, but at present she is not. Medications for opioid use disorder. Actually clicked no, but I meant to click yes. So that is an error on my part. But she has had, she has been on methadone in the past. And currently she is on Suboxone. So a little more history. She's been admitted, like I said, to the hospital multiple times in the past. She has been on our residency service as well in the past. So I just wanted to highlight, as we all know, there are certain gaps currently in those individuals with addiction and those who have found treatment for their addiction. We're hoping to help close those gaps here in our region. But she had been admitted for various substance use related complications, including multiple abscesses, cellulitis. She had very poorly controlled or uncontrolled diabetes as well, which led to osteomyelitis and amputation of her right lower extremity. So I just wanted to present this case, for one, to highlight, the type of individuals and patients we have here in our community as well. It's very similar to some of the large communities. I did my addiction medicine fellowship in Memphis from 2022 to 2023. Very similar in terms of the acuity and of the patients like we have here in Victoria. Also kind of to show, in a way, the gaps in care that may arise. As I said, the patient had been admitted multiple times to the hospital. We had seen her in our residency clinic since 2020 as well. So just wanted to highlight some of those issues and may be able to discuss how we might be able to close those gaps, especially in areas with lower resources, especially in the rural communities as well.
Thank you so much, Dr. Handayan, for bringing this case and to us. I would like to open up the floor for any questions or comments from our learning community here.
Dr. Miramontes, Daniel, thank you for the presentation. I was going to ask you, she's on Suboxone now, so it's kind of a mute point, but at any time, since she is a polysubstance use person with an alcohol flip, did you discuss maybe using naltrexone as a way to combat alcohol cravings and or opioid use disorder?
Yes, we did discuss that. So I gave her the options of going back to methadone, or using Suboxone and naltrexone as well. She didn't want to use methadone because transportation is an issue. We only have one methadone clinic here in Victoria. The closest one would be in Corpus Christi. Also, due to financial constraints, she is on disability, receives a Social Security check. So we determined, we discussed all those options as well. Found to try, she wanted to try out Suboxone because she had heard about it before, but she had never tried it before. Interestingly enough, we had started her on 8 in the hospital. When I saw her in the clinic after, this was about a couple weeks afterwards when we started our addiction medicine clinic here in the residency program, we had talked about increasing it to 16 milligrams. But then we determined that, she was doing well in the 8, and we had gone up actually another half a film to 12 milligrams. And she'd called back and she said that that's too much. So we went back down to 8 milligrams. I'm going to see her back again tomorrow. We're working on getting her into the local recovery outreach center here as well, because they have an affiliation as well with Be Well, from what I'm told. So they're gonna assess her there as well, because she does have a pretty extensive psychiatric history. We also have a local MHMR. It's called the Gulf Bend Center, and they service the whole region. Although, from what I'm told, they don't manage substance use. So that's kind of where we're at in this area in terms of resources. So we have the local recovery outreach center, which is called the Billy Catan Recovery Outreach Center. So hoping that she got plugged in over there, and we're going to discuss that tomorrow.
Thank you. I see a question here from Kristen. Has she been screened for, or is she being treated for depression?
So yes, currently she is being treated for depression. So that's where the difficulty lies in individuals with co-occurring disorders, especially in this region. So we're hoping once she gets evaluated at the local recovery outreach center, they can get her plugged in to other resources that may be able to better manage co-occurring disorders. But our whole goal essentially was to screen her for opioid use disorder while she was in the hospital and start her on treatment. And then get her plugged into the local recovery outreach center, kind of like a warm handoff, since I know the guys over there at that recovery outreach center. So we'll see essentially how we can help her out.
Thank you. Were there any other comments, or maybe you can share about similar patients you've treated?
We have, I would say, quite a few patients. When I was a resident here, we had started patients on Suboxone because there was a need. I guess you can say a psychiatrist who was managing some patients in Corpus Christi, this is my second year of residency, had stopped seeing patients, we can put it that way. And so we got a large influx of patients who were on multiple medications. Some of those included Adderall, Xanax, temazepam, and Suboxone. So that kind of led to all this, I would say. So we had patients that we were weaning off some of these medications. We were trying to get them established with psychiatrists in town and out of town. Like I said, our local MHMR, it's called the Gulf Bend Center, has a little bit of a wait, like many of those resources in smaller areas. So that was a little bit of a struggle. So essentially we did what we could, if you want to put it that way. And not much has changed, although now that Be Well is affiliated with our local recovery outreach center, I'm hoping things will change.
Thank you. Any other questions for Dan here? The room is awfully quiet today. Right. Alanna, can I request you to perhaps help in summarizing today's session for us?
Yes, thanks so much, Dan, for presenting that case. Really appreciate it. And thanks, David, for your input as well. So we talked today about successes and barriers, or facilitators and barriers to implementing hospital-based opioid use or other substance use treatment programs in hospital settings. And then Dan shared a really interesting case of a patient with multiple substance use, navigating the appropriate medications or treatment options for their recovery goals, including kind of deciding between appropriate medication options, naltrexone, buprenorphine, methadone, and figuring out what worked best for that practice setting, especially considering your rural geographic location.
Thank you so much, Alanna. And thank you again, Dan, for bringing this wonderful case to us. And thank you all for joining today's session. This has been a wonderful session. As a reminder, to earn CE credits, please text the activity code 1009-5784 to 844-502-1338 by midnight tonight. We also request you to complete the post-session survey using the link in the chat. The survey will be open for 1 week. If you would like to present a case, please email bewelltx@utisca.edu. We look forward to seeing you at our next session on Thursday, June 20th. Have a wonderful rest of your day. Thank you.